Welcome to the Health and Human Services Committee hearing. I'm James Kavanaugh, Douglas County Commissioner and Chairman of the Health and Human Services Committee. I thank you all for taking time to stop by. We have a brief but action-packed agenda here this morning, and so I'd like to start off with the CEO of the Douglas County Health Center, Jean Hartnett, who's been good enough to prepare some remarks for us. And just so you know, both of our presenters today, both Ms. Hartnett and Sherry Glassnap, have provided us with materials, and so if you want, they've brought copies, and thank you for doing that. And I think Jean has it on the PowerPoint. I don't know, then you do too. Okay, so without further ado, Jean Hartnett, CEO of Douglas County Health Center. Thank you, Jean.
Good morning.
Good morning.
Good morning, everyone. Some of you have heard this presentation very recently, as recent as last Monday. But it's nice to get practice to talk about this in various forums, so I appreciate the invite today. And as Commissioner Kavanaugh indicated, I'm going to very briefly explain to you the impetus for this work plan, what we're attempting to achieve in fiscal year 1920 at the Douglas County Health Center. So a couple of weeks ago, or actually it was a couple months ago, the executive team and I went off-site and had a workday session that was facilitated by a group facilitator to really help us think about the work that needs to be accomplished in this upcoming fiscal year. And we did it primarily right before budgets were due so that we could really think about not only what our strategy was going to look like, but how through this work plan we attempt to have our culture evolve and then also assign the appropriate resources to the strategy. So I always like to start because not everybody is really attuned to, at least the public isn't always attuned to, the environment in which long-term care providers are operating in. As we know, we celebrated very recently the expansion of Medicaid, which means that with the Affordable Care Act that the state of Nebraska has decided to allow for more Nebraska citizens to apply for and receive Medicaid dollars and Medicaid coverage. While this is absolutely a celebration, it isn't so much a celebration when the number of people that are determined to be covered expands, but the pot of money in which we're drawing from does not. So that most definitely from a macro level is going to impact the health center, and we're uncertain just how exactly, but we know it will have some type of impact. On the other side of our revenue streams, our other payer, our other largest payer being Medicare, they being the Centers for Medicare and Medicaid Services, are attempting to change the payment model in which physical therapy, occupational therapy, speech therapy, that utilization of those particular modalities are going to be highly scrutinized. Most long-term care facilities and skilled nursing facilities across Nebraska and across the nation have really relied on their Medicaid dollars to finance their operations. And now the CMS is telling us that they're going to really look at how therapy is being paid for and scrutinize that use. I also talk about in many different forums this notion of unfunded mandates. Unfunded mandates, which I will get into a little bit later in this presentation, really talks about those regulatory requirements that are put on us that we have to follow, but we don't get additional dollars in which to operationalize them. The 5-star calculations, just for those who are new to long-term care, 5-star is a designation that all nursing homes receive that really describes the quality of care that's being provided in your nursing home. Right now, as many of you know, Douglas County Health Center has always achieved the 5-star rating, which means we're the creme de la creme. However, the CMS again is looking at those calculations and may be changing the way that those 5 stars are calculated. The reality then, to boil it down to the health center specifically, is that we rely on, at the Douglas County Health Center, Medicaid to fund 76% of our patient days. However, because of the lack of funding or the amount of funding we receive, it only represents 54% of our funding. As we know, if you've ever been to the health center before, while I show great pictures, it's a really outdated physical plant. So it's not uncommon for us to work very closely with public properties and environmental services to really improve the interior and exterior of our building. And anytime you're improving a physical plant of that size, that's an incredible amount of capital dollars that are expended towards that effort. As I mentioned, the unfunded mandates, those are what CMS is calling the requirements of participation. This is the most significant regulatory upgrade to nursing home regulations since OBRA 87. And it is estimated by the CMS that in the first year of implementation, which was in 2017, that it's going to cost facilities roughly $62,000 in that first year, which again would have been 2016, and $55,000 after. And we're most definitely seeing that with the hire of a compliance officer to make sure that we're compliant, and then getting all of our ducks in a row to ensure that we're compliant with the new regulations. Again, indicative to the health center and indicative to the county, our salary and benefit costs are simply just outweighing reimbursement. And then finally, locally in Nebraska, if you've read the news, going back as early as April of 2018, 21 nursing facilities have gone into receivership, which means they didn't have the funding to bankroll payroll, so they turned over their operations to the state. I can give you an update that since that time, those 21 nursing facilities, 5 of them have actually closed their doors. So I suppose I'm teeing up for you some grim circumstances because I do think it's grim. I have been in long-term care in either a caregiving capacity or a leadership capacity since the late 80s and early 90s, and I've never seen things as dire as they are now, whether it's regulation, reimbursement, or attempting to achieve the triple aim. It's getting more and more difficult. So with that context, we really are looking at, from an executive level at the health center, how we can combat these challenges that are inflicting long-term care. We at the Douglas County Health Center want to be around for 100 more years at least. But unless we change the way that we're doing business, then I don't know how feasible that is unless we continue to ask taxpayers to fund our operations. So we really are looking at strategy and culture. Strategy, really, when we think about it, this definition from the Harvard Business Review is the most apropos, as it really looks at organizational viability and effectiveness. And that really was the focus of our off-site meeting, was to really look at what strategies can we employ in order to maintain sustainable operations. With that, 3 guiding principles when we met off-site really emerged. We didn't talk about these and start calling them out until we started dialoguing about the work that we need to achieve. So the guiding principles that are guiding this work plan are around sustainability, modernization, and excellence. And the middle column there, the requirements of participation, program development, electronic medical records, and the partnership that we are engaging in with the VA, or the Veterans Administration, we really hope that that work will help us achieve the outcomes of the triple aim, which are better care, better outcomes at a lower cost. So I'm going to drill down just a little bit on those 3 guiding principles so you have an understanding of why was it sustainability, modernization, and excellence that emerged as the guiding principles. Well, I will show you this diagram here, which is from the Medicaid cost report. So this is comparable nursing homes to the Douglas County Health Center. And it demonstrates or illustrates to all of us that the way in which the Douglas County Health Center is operating currently from a dollar standpoint is a lot higher than other nursing homes across Nebraska. Tabitha Nursing Home has the equivalent amount of beds, and you can see that their total operating costs are a lot less than ours. So that is one of the graphs that is, or one of the components, or one of the pieces of data that's really driving this notion of sustainability and what can we do about it.
I think one of the issues with that, Gene, is probably...
Excuse me. We're just going to...
sorry.
Excuse me. We don't have too many rules here, but if you want to speak, I want to recognize you. No problem.
Okay.
Just so folks will know, we'll try to keep it on an organized basis. Patrick.
Thank you. So, Gene, that 311, a lot of that resulting the personnel costs, salary and benefits.
Absolutely it is.
And I think one of the issues with that is that when we do comparability for union negotiations, we look at jurisdictions outside of the state, and rather than inside, and we don't really look as much at private facilities. I
Sort of do a
kind of do
combination,
a combination
just because
of the
there
two.
aren't that many jurisdictions that have something comparable to what our organization is. So we try to look at other jurisdictions, but we don't have a strong number of them. So then we also, Jean provides us and Sherry some local numbers if they're able to get that as far as the nursing hourly rates.
And a lot of jurisdictions have privatized their facilities, so it's not exactly apples to apples because we're a government facility compared to private facilities who might pay lower salaries or benefits. So it's a little tricky. I mean, it's just almost the nature of being a government facility. You're going to have higher personnel costs.
So I think that's an excellent point. And, you know, we come up against this again and again in our comparability studies that we do for our collective bargaining units across the board. And a lot of times these end up in the Court of Industrial Relations, and they live or die on comparabilities. So based on this graph, did I understand you to say these are comparables within the state of Nebraska? Is that
Correct. Yes.
Okay. And is there another unionized health center like us in the state of Nebraska?
Not that I'm aware of, neither unionized nor county run.
Okay.
There is a smaller nursing home in western Nebraska that is county run. Lancaster Manor and Rehab Center that is displayed on this graph was government run. It was very similar to Douglas County Health Center in that the Board of Trustees and Commissioners were the operating body or the governing body. They, as Patrick mentioned, they have since privatized within the last 5+ years.
Right.
And you've really seen, to Patrick's point, their neutralization of their costs relative to the operation, that they have been able to impact their cost from salaries, again, because there isn't this automatic upgrade or automatic salary increase from unions and also collective bargaining and the civil service.
Right. So, you know, going forward, and the thing that really intrigued me when you presented this to the trustees was that, you know, you're asking some of the same questions that we're all asking, but to kind of fine-tune it a little bit, would it be possible, like we do in all other of our labor negotiation settings, to find actual comparables, ideally, in the region? So you would find a county-owned, unionized, somewhere in the region. This is what we would do in the normal course of labor negotiations. If not, you know, nationally. I mean, you go out kind of in a concentric circle and find it. Would that be possible to do that? Because this is an excellent document, but I view it as kind of a starting point. I think that's how you portrayed it to us.
Yeah.
And this is kind of a starting point hearing. So this is a good time to be talking about these things. But the point that Patrick and Diane was making is really on point in terms of the exact question of costs that you're talking about.
Yeah.
If we are to get a realistic handle on our costs, we have to have as Patrick put, apples to apples. And we're not really getting that here. No criticism, but
Sure.
there's just not another apple in Nebraska like our apple.
Right.
So-
Yes. Your point is very well taken. And I think I display this not to suggest we need to reduce staff or change the way that we negotiate with the unions or change the way that we incentivize staff, because I most definitely am very much for paying people for a job well done, and I think our staff does that. What I'm merely suggesting is that this is the reality in which we're operating in, and if this is the reality and it's not going to change, then what are those strategies that we can put together to really mitigate future operating cost loss?
Right.
So it's yes, I most definitely will look for that
That would
data.
be great.
Mhm.
Patrick?
So can you explain what these numbers mean? So are they cost per patient per
Per
hour,
patient.
or how does that just?
The way that the Medicaid cost report breaks this down is cost per patient day.
So $109.78 per patient day for nursing, for like the Nebraska skilled nursing and rehab. $184.62 per patient day for Douglas County.
That is correct. So it basically just shows you what that would translate into really our bodies. How many individuals are we employing or deploying to work with our residents, whether in all of those different areas. So those are definitely indicative of salary and benefits cost.
I mean, we've always been a 5-star facility, largely based on our staff,
Correct, and I show that.
which you can look at it. We're adequately staffed. Maybe in some areas we might be too heavily staffed.
Sure.
So I've always just kind of looked at that 5-star rating, because the quality star rating is a 3. So, I mean, it's a little bit misleading to say it's a 5-star facility because the quality is a 3, the staffing's a 5, but I never really did quite understand how that all played.
Well, that's an excellent segue into this next page, this next slide. So, as I mentioned at the top of the presentation, the 5-star rating calculations are going to change. And I don't know enough yet to be articulate to explain just what those changes mean and how they may impact the health center. What I can tell you is that the way that the calculations are currently derived is through these 3 components. So health inspections, which is when the state comes in and surveys us every year, a staffing star, if you will, for how many people we employ and deploy to do the work, and then our quality measures. So you would look at the former page and the former slide and think to yourself, well, you've staffed so high, that should translate into higher quality, very, very much to your point. And here it doesn't. So that's where you really have to start thinking about, okay, what is it? We've got a lot of staff, but what is it that those team members are doing that isn't necessarily translating into 5-star quality? And that's something that we are drilling down into and really trying to understand just what is tipping the scales to be an average of 3.
So CMS does this on an annual basis, is that correct?
So CMS does our annual health inspections on an annual basis.
But this ranking,
The ranking will come out every month, and because every month we have to report into the CMS what's called our payroll-based journaling. So really verifying for them the amount of staff that we have. Your star can also change if you have events in your facility that have been investigated that were adverse events towards residents, so that can put your quality measure down. And say, for example, if we decided not to staff with as many nurses as we do, or as many dietary staff or housekeeping staff, that could also impact that rating. So they're frequently updating it.
okay. So when they give us this monthly update, do they give us notes on health inspection, notes on staffing, notes on quality measures?
No, we don't. We do get a report that I'm going to present at the Board of Trustees to really help the trustees understand that quality measure component. Every resident, just to get super granular for you if you're so interested, every resident that's admitted to the Douglas County Health Center is assessed based on about 535 elements of their care. And it literally is that exhaustive of a tool. The tool is called the minimum data set, and it's been around again since over 87. And essentially is the roadmap of what it would take to take care of a Mr. Lorenz versus a Mr. Kavanaugh. And from that assessment, in which it's completed by a registered nurse, then we understand just exactly what this resident needs to be cared for. That MDS then is updated every time there is what's called a significant event. So if they fell, if they're dehydrated, if they developed an infection at the health center, we then have to redo the MDS. And that all of that data is transmitted to the CMS, and that is where they calculate, not just on an individual level, but on a population health level, just exactly what you look like quality-wise.
So, kind of going back to another point that Patrick raised relative to that, we have a 4, a 5, and a 3. I guess if you average those, I'm not a numbers guy, but it doesn't come out to 5. But we're, posting a 5, which I'm happy with. I think that we do have a quality facility. The question I have is to get that, say, quality measure 3 to a 5,
Mm-hmm.
we have to know, well, what are you giving us a 3 for? If it's my algebra test, which ones did I get right and which ones did I get wrong?
Yes.
Is that the MDS if you take all the individuals and then you measure them down into an average? Is that how that is determined?
Yes and no. So let me go back to that, the fact that these numbers, when you average them, do not equal a 5. And the reason for that is that certain measures are weighted more heavily than others.
Right.
So staffing, we get kind of a 5 to the numeration, or to the power of 2.
Okay.
So that one is weighted higher. To your point around how do we not know how to up our quality, basically the data that we transmit to the health or to the CMS is outdated information. Meaning, once we get the calculation, they're calculating it on care that was given 2 or 3 months ago. So it's not real-time data. We can most definitely drill down on the quality measures themselves. As I mentioned, Commissioner Boyle has asked me to present more in depth on what those quality measures look like, so I can give you more of a sense of how they're calculated and exactly what they're looking for. And then to your point, how are we attempting to influence it to get it up?
Okay.
Yeah.
Thank you.
Anything else on this? Yes.
Yeah, when you broke down, the cost of the 4 different units, it looked like we had the highest cost. But if you look at revenues, are people being reimbursed differently per patient on a per patient basis? I mean, are we recapping some of that difference on the revenue?
Not necessarily. So again, with the MDS, that tool is not only a care planning tool, meaning, again, how to take care of Mr. Lorenz versus Mr. Kavanaugh, but it's also a financing tool. So if Joe is relatively independent, meaning he can get himself up in the morning, he can take himself to the shower, he can feed himself, make his own decisions, his care level is going to be a lot less, and the amount of resources we need to put into Joe are going to be a lot less. The CMS is going to pay us a lot less. Whereas if we had a Commissioner Kavanaugh who was in a motor vehicle accident 20 years ago, now he's had a stroke, he's unable to use his hands, he needs help with everything, whether it's using the restroom or getting up in the morning or getting dressed, that will kick his care up into a higher level, in which we will get reimbursed higher for.
Thank you. Joe, if you want to be recognized, raise your hand,
I'm sorry.
please. staffing that we have, this 5 that we have, it's the best that you can get. It seems to me, in my mind, to be related to the fact that we've got people over there that have been there for their whole careers, which is a good thing. Continuity of care is a good thing.
For sure.
And part of that might be because we do pay well relative to these others that you compared to. And so, that's kind of interconnected, I think. Whereas if you just look at, okay, well, we're out there paying more than XYZ or whoever, and that's, kind of a warning sign. Yes and no, because staffing is our best point in this whole thing. And I got to think that compensation is a huge portion of our staffing continuity over time. I mean, I run into people all the time, been there 30 or 40 years. I mean, that's impressive.
Yeah.
I don't know too many organizations that have that kind of a component.
I would agree.
I'm sorry, go ahead.
Okay. So, anything else on quality and excellence? So,
I'm eager to get to modernization because we've been joined by our crack public property staff, and this, I think, plays into their bailiwick a little bit.
wonderful. Yes, the notion of modernizing is something that, since I've been at the health center, that I've really talked about as a major theme that I'd like us to focus on. To me, modernization applies to all aspects of our business. And I truly think before we can innovate, before we can take on any notion of innovation in senior care, that we have to modernize first. And I've been asked, what do I think the difference is between modernization and innovation? Because people confuse them and think that they're similar. To me, modernization is just bringing your operations, your physical plant, everything that happens inside of your building to where your competitors are. Innovation allows you then to really surpass where your competitors are. At the health center, we have been doing things in long-term care and providing care to seniors that really are antiquated types of ways of delivering care. And one of my best examples is the fact that we're still charting on paper. And that is something that just doesn't happen in long-term care facilities any longer. So this notion of really bringing our operations up to a modern standard, I think, will allow us to focus on more efficiencies in our operations. Our systems and structures need modernized. Our policies and procedures need modernized. Our roles and responsibility, what does an RN do versus a CMA versus a CNA? The physical plant itself, again, that is an extraordinary capital expense when you think about the amount of asbestos that we have to abate from time to time. And then, of course, the technological advances that we need to employ in order to keep pace with our competitors.
Now, just to pause there for a second, relative to the physical plant, as long as we've got our physical plant people here, I know that traditionally we have a deferred comp list that they maintain. It's long, it's inexhaustible, and like any organization that owns the property that we do, it never will end. But are you familiar with, just in your plant, the deferred comp list that public property maintains on your physical facility?
Yes and no. I'll answer that in two ways. Public properties has always been, first of all, a great partner for the health center. And we have attempted to align our priorities, if you will, in terms of what is it that they're interested in paying for and what we're interested in paying for. So yes, I've worked with Jerry and Jeff fairly closely in past fiscal years to really align what their priorities versus our priorities are.
So, in your mind, as the CEO, if you had to pick 1, 2, and 3 physical plant stuff that you could wave a magic wand and change, what would those be, if you know?
It'd be a new building.
An entire new building?
Yes. You said the wand, right?
Okay.
Yes. If you want to restrict my wish list, I think at some point we do have to, figure out how much more money do we want to pump into a building versus looking at new construction. And I'm not advocating that we go in either direction.
Well, you just did.
Well, again, if I had a magic wand, I think that is what I would do. The way in which we're organized from a neighborhood standpoint, and the way that we have to deliver meals and deliver meds from the pharmacy, it just is, I don't want to say chaotic, because I think we do an excellent job, but it certainly can be organized in a more efficient fashion.
Okay.
Anything else on modernization?
You mentioned system structures. Give me an example of that.
So essentially, when I think of system and structures, I think of the way that it's really more of the soft system and structures, the way that we hire people, onboard people, train people, performance evaluate people. A lot of the systems and structures we're borrowing from the county, whether we're working with the civil service department or what have you. But there's a lot of opportunity to kind of wring out the kinks to make our systems and structures run more effectively.
Okay. The tech updates, we get these reports at every trustee meeting relative to electronic records. And it seems like the event horizon that never quite gets there. Is that a tech update that we are close to realizing? I mean, you mentioned we're on paper and we should be like the other health centers,
Yeah.
maybe moving away from that.
Yes, the tech promise, the promise of tech or the promise of EHR, I do believe is going to happen this year. The individuals that .com has employed recently from a building standpoint have really been able to make up an incredible amount of lost time.
And that's the one that reports, I believe, is Diane Walls. Is that
She
right?
does, yes.
Okay. So that's going to come to fruition in 2019?
Correct.
Right.
Barring anything that I am unaware of. But yes, again, I feel very confident in the folks that .com has been able to recruit to make that happen.
Right.
I will very briefly, in the interest of time, go through then one of the items that we talked about or that I outlined for you is a major chunk of our work in fiscal year 19 and 20. This, I will go on record to say this will not be completed by the end of the fiscal year 2020 because it's an incredible culture change that we at the health center from the executive staff level firmly believe will help in all areas of our guiding principles. So program development is this idea of really going back to our mission and really thinking to ourselves and getting feedback from frontline team members on what is it that we do best. When the short-term rehab program ceased to exist about 60 to 90 days ago, it really allowed us an opportunity to say, okay, what is it that we're good at? And what we're good at really fell into 3 different buckets, and we've since added a 4th.
Hello.
So when we thought about what we're good at, it delved into developing a behavioral health program, continuing to be excellent in memory care and serving those with dementia, continuing to serve those individuals that require long-term care for medical reasons, the example I gave after your fictitious car accident. And then this 4th program that we're really interested in developing called Independent Square. So essentially right now when we admit people to the health center, it's more of a shotgun approach than a rifle approach. Meaning if we have an open bed in X neighborhood, we'll attempt to align your needs with the type of individual that we're already serving in that neighborhood. What we're attempting to do with program development is to get really clear on each of A, B, and C on who we're admitting. And then deciding as we update their care plans and update what's happening with them, do they still belong in these different programs? So we have a lot of individuals who admitted to us in quote unquote a behavioral health program that because of programming, pharmacological interventions, and just regular care, they're doing a whole lot better. So is it possible that these individuals no longer need to live in an institutional environment and we can transition them into a community? We don't know because we've never asked that question.
So does that happen very often? Do we discharge people into the independent community very often?
We do not. And so you will, if you have been around the health center, which I know you have, Commissioner, you see that we're very different. Our demographics of who we take care of is very different than your traditional long-term care facility.
Oh, I know a guy who's been in there since I was in high school.
Exactly. And I think I know who you're talking about. But is there a way that we can think about individuals differently and really, again, align them with the appropriate program on their journey, on their lifespan journey? So it is looking at this a little bit differently, and regularly updating that individual's care plan to say, are we serving them best? So that essentially is how that will look. So if you start in a dementia care program, for example, I'll use that as the best example because most people are familiar with dementia, and you're an early stage person with dementia, meaning you can still get yourself up, you can still bathe, you can still dress, and you can still eat independently. Over time, with your dementia, your physical needs will surpass the mental needs that we're attempting to help you with, so that you will become more dependent, you will become incontinent, you will lose the ability to walk, you will lose the ability to eat. So that is when that dementia care person becomes more long-term care medical. And so right now in our dementia care program, we have individuals who are totally independent, who are more of a long-term care medical person than they are a dementia person. So while we want to keep those individuals at the health center, we want to move them to a program that is most appropriate for them at the time.
Well, that's great, and this is really great. I want to urge everybody who hasn't had an opportunity to maybe take one of these plans. This is exactly how we should run the health center and plan for its future. I commend you and your staff on doing this. The reason that we have these public hearings in addition to the trustees is simply to allow the public to come in. I mean, there's rarely, if any, public at the trustees meeting, and so they're more accustomed to being at these meetings, and then hopefully as we go on we'll have a little more robust public participation, which I think is good. They own the place. So we've had questions and input from us here at the county. I would ask if anybody from the public has any questions for Ms. Hartnett. And this isn't going to be your last time to get this opportunity, but we have her for a limited period of time. She's busy and runs a big organization. So if you've got any questions, speak now or hold your yes, sir. You have to identify yourself for the record, please.
Luis Jimenez, 518 North 40th Street. Thank you, Mr. Kavanaugh. Hello. I just want to make a point that not too many people know about the county hospital. That's kind of odd if you think about it. I didn't realize that other places in Nebraska didn't provide public ran or operated facilities. I do, though, have a question. Do you provide reports or information on trauma-informed environments?
That's a great question. So we have, as I mentioned, the requirements of participation, which is the mandated regulatory upgrade, if you will, that our payer is requiring us to do. By November of 2019, so by November of this year, we have to have a trauma-informed workforce, meaning we have to train all of our staff on trauma-informed care. So we are on pace with understanding just what that means in a geriatric setting and getting our arms around trauma-informed care for all of our individuals that work at the health center.
Okay. So it's for the staff?
Yes.
And you guys consider your facility trauma-informed?
Not yet, but we will be because we have to be.
Oh, okay.
Yeah, and trauma-informed is such a buzzword, and I I welcome the discussion on how to implement it most effectively in
Yes,
geriatrics.
definitions help.
Yeah.
Yep.
Yeah, but we're getting there. We're definitely getting there. Again, we're mandated to, so we'll most definitely follow the law.
Thank you.
Mm-hmm.
Chair,
No.
Larry Store.
Yeah.
Going back quite a few years, starting with my mother with dementia and then a grandson with special needs.
Yeah.
How will you carry this culture feeling through to the staff?
Mm-hmm.
I have so much thinking where, in a lot of cases, the staff ought to be the ones that are committed, not the patient.
Mm-hmm.
This goes back a lot of years because there's not enough follow-up to the goals, to the ideal. You sound very warm, very convinced, and heartfelt, but that has to get carried on through the people that actually do the work.
Yeah.
So my final question would be, children that are in the transition program from, say, DD services or behavioral problems, in Nebraska, it's hard to tell whether they're making the majority age 16 or 19 or 18 or 17. But they can be in this program until 21, and then maybe they're out on their own, flat-faced. Is there something for those children that are not going to make it
Yes.
once they have to walk out that door to complete independence?
Well, hold on. I'm confused. Children. What children are you talking about?
I was just going
Well,
to.
children that have become adults, they've been in the system.
This is not. This is about the long-term care facility.
All right, but I'm a child, 19, I have a problem. I'm 21, I have a problem.
Okay,
I'm an
okay.
adult.
We
I'm
got
an
limited
adult.
time here, so
I'm an adult.
Ms.
How do I get
Hartnett,
in?
I understand.
Okay.
Thanks, Larry.
How do I get
If you
into,
have, I understand that. If you have a response to what he's talking about, because we've got another
Yes.
whole presentation to go through.
So I will tell you the culture change component is the most challenging component. Since I've been at the Health Center, I've been really hammering at the notion that we can have a for-profit mindset with our nonprofit hearts, and I do believe that. The other component around developmental disabilities, intellectual disabilities, those aren't, the younger population is not the population that we serve. So
What's the minimum age?
minimum age to be admitted to long-term care typically is 19, but you have to meet nursing home level of care. So there's a screen that the state and the feds require that we do to make sure that we aren't inappropriately institutionalizing individuals that could be better served in the community.
Okay.
Yeah.
And possibly going forward, and thank you for that, we might hold one of these on Douglas County Health Center ground to give people an idea of the excellent organization that it is, because there is a mission statement, you're talking about the culture, in the front lobby, engraved in marble, that is absolutely spot on, the best I've ever seen in any health center that I've ever been in. But the work that they do, I think you'd have a much better grasp of actually going there and seeing it, so we'll do that. I think that's all, unless someone else has a question for Ms. Hartnett. Thank you very,
Yes.
very much.
Yes.
This was excellent.
Yeah, thank
Appreciate
you.
it. Again, we have copies of the Douglas County Health Center work plan for 1920. If you have not signed in, please do, and we will move on to our next presenter.
Is there a keyboard that controls?
Do we know how
It
this
should be in the
works?
cabinet, right?
Okay. No.
There is one somewhere.
What do you need, a stick?
Keyboard.
The keyboard.
Oh, in addition to our public property director and deputy director, we've been joined by the director of Douglas County Corrections Center, Mike Myers. Thank you. We know from our monthly Correction Center reports that he presents to us, which are excellent, that a high percentage of our census population at the Douglas County Correction Center presents with mental health issues, which segues nicely into our next presentation by Sherry Glassnap, who is the director of Douglas County Community Mental Health Center. And as soon as we overcome our technological glitches here, we'll move into her presentation. There is a hard copy here for those of you like me still in the analog age of paper.
Anybody else want one? Oh, yes, please. Here? Yeah. Yeah, so. Thanks.
Or maybe not.
Yes, thank you so much. I appreciate the opportunity.
How do I get this? Does anybody know how I get this to where it's just one slide versus?
You just gotta go up to the slideshow.
Yeah.
To view,
Oh boy, the mouse is really.
and then just from the beginning. To the very left. There you go.
Thank you.
Okay.
All right. Good morning, everybody.
Just a Calvin.
Sherry Glassnap is the director of Douglas County Community Mental Health Center. Thank you for joining us.
Oh, thank you for having me.
And thank you for this presentation. Without further ado, I'll let you get to it.
Okay. Wonderful. As Commissioner Kavanaugh said, I am the director of the Douglas County Community Mental Health Center. Okay. So I was going to briefly go over our mission, vision, and values of the services that are provided at the Community Mental Health Center. We are one of 3 departments that are located in the Douglas County Health Center. As Jean indicated, the health center programs that work with individuals with long-term care, the services that we provide at the Community Mental Health Center, and then also the primary health care clinic. So our mission is to provide hope by offering high-quality, comprehensive mental health care for the underserved of Douglas County. So the underserved really are individuals that are indigent and those individuals who have Medicaid that cannot provide or cannot find other behavioral health providers. Our vision is to provide high-quality mental health services in the community. And our values are care that instills hope and is patient-centered, respectful, accessible, culturally competent, and economically responsible. When we developed our mission, vision, and values, one of the things that our team chose to do, and we believe this is absolutely imperative, as we had one of our peer support staff members intricately involved in this process. So a peer support staff member is somebody who is in lived recovery. They have been through and received behavioral health services, substance use services, and maybe possibly also been in Douglas County Corrections. And so they were one of the founding individuals that were in the team that helped us develop this. So this mission, vision, and values is the foundation for all of the services provided at Douglas County Community Mental Health Center. We have 2 psychiatric inpatient units. We have an 8-bed psychiatric intensive care unit, and we have an 8-bed general adult unit. So this program is for individuals who are 19 years or older who have an exacerbation of their mental health and or substance use symptoms and are having a very difficult time taking care of themselves in the community. They are considered an imminent danger to themselves or others. Therefore, they're in an acute care facility receiving services from a psychiatrist and then the team that works with them. There are staff members there 24 hours a day, 7 days a week. The average length of stay on our intensive care unit is approximately 4 days.
I'm sorry, is how long?
Approximately 4 days. So the goal of the goal of a psychiatric inpatient unit is acute stabilization. So once the individual's acute symptoms that brought them into the facility are stabilized, we are bound to discharge them to a lower level of care.
And in the general adult inpatient unit, what's the average length of stay there?
They both run about 4 days.
Okay.
And we do have individuals that will be there longer. if they are having a difficult time stabilizing, or they could be waiting for, maybe they're a Board of Mental Health committed individual and they're waiting for services at the Lincoln Regional Center. They're having a hard time finding services within the community, and they're not stabilizing as well as someone else. Okay. All right.
You've heard me ask this before, just to get it on the record. We have no long-term mental health care beds in Douglas County. Is that correct?
That is correct. Okay. The closest thing that we would have would be Telecare's secure residential program, but it is not long-term mental health stabilization. Okay. It should be noted that I believe we have more individuals that we are working with than before with our partner from Douglas County Corrections. So there are many times where individuals are in Douglas County Corrections. There's an exacerbation of their mental health symptoms. If the charges allow, the charges are dropped. If the county attorney determines it's appropriate, a Board of Mental Health petition is picked up on that person, and then they are placed at an acute care facility within our community, and we are one of those facilities that will take those individuals. The goal is, again, to stabilize those acute symptoms and then transition them to a lower level of care.
I'm glad you brought that up, and I appreciate Mr. Myers being here today, because, the overlap in populations between our corrections population and our mental health population is, 50% in that institution. And a lot of those folks are in there because they present, their mental health problem presents in a way that is technically in violation of some law. Okay, I could go on, but the problem that we have is placement. And we're trying to work on that, and I'm glad to hear that the coordination is going on. And we'll have probably another hearing devoted simply to that. But that's great, and I appreciate Director Myers being here, and I think it's an important element going forward that we don't use our corrections center as a long-term mental health care center, which is essentially what a lot of these people are getting in the current environment. So thank you for bringing that up.
I think that Mike and I try to work very closely together whenever possible. So the step down from inpatient are psychiatric outpatient services. There's an array of services that we provide at the Community Mental Health Center, and we are very lucky to have a continuum of services. There are many facilities that may not have a continuum of services for individuals to step throughout their ongoing stabilization. We have a day treatment program. That program provides services Monday through Friday, 9 to 3 for individuals. So they come in during the day, they receive therapy, they receive education, they see their doctor, they have individual therapy, and it provides them with some structure and continued stabilization. Outpatient medication management. That is where an individual comes in and sees either a psychiatrist or an APRN for ongoing evaluation and provided for their medications as well. Luckily, we have at the bottom, you'll see it's pharmacy. We have a pharmacy on site that is actually operated by the Douglas County Health Center. It is absolutely imperative for an outpatient medication management provider to have a pharmacy. If you can imagine going into your doctor and getting a medication, let's say a prescription for your cholesterol medications, but having no way to fill that, not having the financial resources to do that, would be devastating for you, and you wouldn't be able to take those medications. So I think that's something that is important for us to highlight and important for us to emphasize how that partnership absolutely needs to continue.
So in this array of services that we provide, we have, is it 4 psychiatrists on staff currently?
We do. We have 4 psychiatrists, a medical director
Okay.
in that mix.
So in this array, is the patient sitting with the psychiatrist and getting psychiatric care, is that reflected in one of these points here?
Yes, that would be called outpatient medication management.
Okay.
They also see a psychiatrist in day treatment as well.
Okay. And so there are people who come in on a regular basis and meet with the same doctor. There's a continuity of care relative to their problems?
Yes, absolutely. And the really nice thing, unique thing about the Community Mental Health Center is when our clients are in our inpatient units, when they transition to day treatment or they transition to outpatient, they have the option to continue to see the psychiatrist they saw on the inpatient unit. So that provider knows them very well and follows them back and forth throughout those services.
Great. Thank you.
You're welcome. We have outpatient therapy. We have an intensive outpatient program. An intensive outpatient program is 12 hours a week of group therapy, specifically focused on working with individuals with their mental health and their substance use issues. And then they also have an additional individual session as well. We do substance abuse evaluations on site and in Douglas County Corrections. We have triage therapy. That is something that we added within the last 3 years and has been extremely successful. So individuals in the community can walk into our program Monday through Friday, anytime during the day, and they will see a triage therapist. That therapist works with them in regard to the crisis that they're currently in and then helps connect them to the right level of care, whether that level of care is within the community mental health center services or, if need be, outside of the community mental health center services. So that is an extreme value added to our facility. We have,
Now, relative to the substance abuse evaluations,
Yes.
we recently took over management of alcohol. What's it
detox,
called?
social detox. Yes, we did.
Right. So, would there be referrals from our substance abuse evaluation to that, or is that just a critical care like ICU for our alcohol detox?
Most of the time, the substance abuse evaluations are going to take place when they're in detox, because detox is an emergency service. So they don't need a substance abuse evaluation to get into that service.
Okay. If we do substance abuse evaluations, do we recommend treatment for
We do.
individuals?
Within that evaluation, the state guides the levels of care that you can refer individuals to. All the staff have to be trained in a specific model to provide that evaluation. And at the end of that evaluation, it will give the recommendation whether it's outpatient therapy, intensive outpatient, or what level of residential treatment that the person needs.
And I note in the next portion that you do regarding the collaborative efforts with Douglas County Corrections that there is reasoning and rehabilitation. I don't know if that involves the same substance abuse evaluation in corrections.
You know, reasoning and rehabilitation is a different model, and you're not required to have a substance abuse evaluation to get into that program. The substance abuse evaluations that we do in corrections is specifically to determine the individual in corrections what level of substance abuse treatment they need when they leave corrections, whether it is intensive outpatient or if it's a residential level of care. There are several different residential levels of care, or it could be individual therapy.
Okay. And I think that we have kind of a robust series of AA meetings, NA meetings in corrections that they can attend.
Yes. We have peer support services. Again, those are services that are staff members that are in lived recovery. We are very lucky to have staff members who have actually been on our acute units, both on an involuntary basis and a voluntary basis, and are extremely stable and now working in the community and giving back. And then we also have another one of our peer support specialists that actually has had services in our social detox program, not while it was ours, but historically. And so it's really nice to have them. They can come sit beside somebody and say, you know, I really truly have walked in similar shoes than you have, versus a staff member who probably hasn't had those services. So it really helps the person, helps the patients, especially on our inpatient unit, to know that there are individuals there that understand that where they've been and where they're coming from, especially when the person is placed there on an involuntary basis and may not want to be there. And then, of course, the pharmacy. Okay. Psychiatric outpatient services. Oh, look, I spelled located wrong. Sorry about that. And I even had 3 people proofread this. Go figure. Located at Douglas County Corrections. So we have a very strong partnership with Douglas County Corrections, probably better than ever, and that's developed over the last 5 to 10 years. It started out with our very first program, which was our mental health diversion program, and then we have added in intensive pre-release and transitional services, reasoning and rehabilitation, and our intensive outpatient program that we operate on the RAP side. And hopefully in the future, we will be able to have an intensive outpatient program within Douglas County Corrections as well. Okay. Social detox. This is our 26-bed facility that's located at 1490 North 16th Street. It is in the Campus for Hope building. It used to be ran by Catholic Charities, and Catholic Charities chose to get out of behavioral health services and substance use services, and when they did, Douglas County took over the social detox services. It is both involuntary and voluntary. 10 beds are specifically for civil protective custody, and then 16 beds are for voluntary services. I will say this program has not come without challenges. I think we're all very well aware of that. But the individuals that are served in this program are some of those that are absolutely in most need. These are individuals that come in, they are very intoxicated, they are overcome by their addiction, and not only that, they may have burned many of the bridges with family members and friends in the community, bridges with services. They are typically highly complex with their medical needs. One of my favorite stories comes from Mike Phillips, who ran this program when Catholic Charities was there. And he indicated he had an individual who came into the involuntary side, brought in by the police, over 100 times. And it was on that, I'm going to say 101st time, he decided, I think I'm going to try social detox. And he actually was able to get through his addiction, and he went on after 2 years of sobriety and having done very well, became a technician working in the social detox program. And so I think that's one of the stories that I love to tell, because it's why we as the county do what we do for the individuals that we serve. Those that are in most need, that sometimes you begin to wonder at times, is this person going to accept help? But if you choose never to give up on the individual and meet them where they're at, which is the foundation of what we do, then hopefully on that 101st time, like that individual, they may accept the help. And
That's really a good point. When we took this over a year or so ago,
it's been 2 really long years.
has it been 2 years?
It has,
Okay.
in February.
The financing of it, we took over that as well. How is that working?
We are still working on the details of that. If you can recall, this is a program that ran for 20 plus years underneath Catholic Charities. When we took it over, some of the things that we found out is that the program required a program national accreditation. The previous organization had an agency accreditation. And so as we continued to dig with the Substance Abuse Treatment Center facility, they indicated that no, you really have to have a program accreditation to be able to get funding from Region 6. So our funding became at jeopardy. So it's been 2 years of continuously trying to work through that. I think everybody's aware that civil protective custody isn't a mandated function of Douglas County. It is something that from my perspective, the Omaha Police Department desperately needs. And so it's really looking at how do we come together to the table to provide services for these individuals so this program doesn't go away. So the Bridge in Lincoln, which is the only other program like this in the state, is primarily funded by the city. And then there's some subsidy by the county, and then there's some subsidy by donors and UNL. So their funding looks very different than what our program has historically looked like. Ours has been primarily funded by Region 6 behavioral health care through state and federal dollars. And then Douglas County pass-through dollars, and then the least amount of funding that we get currently is from the city. So we are still trying to work through that.
Okay. Thank you.
You're welcome. Any other questions about detox? Okay. Facilities. So as I indicated before, we are located within the Douglas County Health Center, one of 3 departments. We also work with Douglas County Corrections and have approximately 400 square feet of office space. So our staff that work with corrections are officed there, which I think is absolutely wonderful. I will tell you that many individuals that encounter our staff at corrections do not know whether they're correction staff or they're community mental health center staff. They have integrated that much with each other, so I think that's very good. And then also the social detox program that is located at the Campus for Hope. That building is going to be owned by CenterPoint. They have the services that are in the other half of the building, and then we rent space from them. This I do approximately once a year, and it's just a map in regard to our outpatient services and the number of individuals that we have in outpatient and what zip code that they're located in.
So can I ask just a quick question on here?
Sure, absolutely.
68106 appears to have no one in it.
That's your neighborhood.
That is my zip code. So are we just
Would you like me to
incredibly
Would you like me to
well-adjusted
recruit?
and
I can go
mentally
knock
well?
on. I can.
Because I know a couple of people in my neighborhood. I swear to God.
I'm guessing you're just hiding. I don't.
What's-
I do not have the answer to that.
The other thing is there are reflected their numbers in Sarpy County, so we do take referrals from Sarpy County. Is that,
We do. Our contract with Region 6 indicates that we will provide services to anybody in the 6 counties within, or the 5 counties within the region.
okay. Thank you.
You're welcome. Great questions. Recent accomplishments. So we are nationally accredited, and that is something that as a hospital you are required to have. So since we have the 2 acute care programs, we are considered a hospital and we are licensed as a hospital. So we have our national accreditation through HFAP, which is for the Community Mental Health Center kind of proper services located at the health center. We also have a CARF accreditation for our detox program. We have secured ongoing funding for our intensive outpatient program, which is located in Douglas County Corrections. Historically, that was a grant that we received, and then we were able to receive that ongoing funding. And then again, the ongoing development of our electronic health record, which will be implemented July 1st of 2019. That is our launch date. We are very excited about that. Our team has just really done a wonderful job. These are individuals who are community mental health center employees who have taken on this task of building the electronic health record and have done an absolute wonderful job. And they have partnered very well with the employees from .com. Our challenges, because we have challenges. I think every facility is going to. 1 in 5 individuals in Nebraska experience a behavioral health concern. With that, obviously, there are going to be more and more individuals seeking behavioral health and substance use services. Provider reimbursement does not cover the cost of services. There is a study that was done by the Division of Behavioral Health. It's called their cost study, and it is on their website, and it will indicate for the services that they have looked at what they are reimbursing and what the projected reimbursement should be. So an acute psychiatric inpatient is reimbursed at approximately $758 per day, and it's indicating that those services should really be reimbursed at approximately $1,000 per day. Lack of appropriate treatment options. So when working with individuals with behavioral health issues, which is mental health and substance use, a lot of times there's not enough services in the outpatient world for these individuals. There are long wait lists for individuals. Individuals that need the Lincoln Regional Center level of care, whether they're in corrections or whether they're in a community hospital, very long wait lists. People can wait for months to get into those services. People can wait for 70 days to get into short-term residential services for their chemical dependency treatment. So those are things that I think it's important for our community to be aware of. I will say for outpatient services, most providers and hospitals in the community will say that there are very long waits to get into outpatient medication management, 6, 8+ weeks. We implemented a model several years ago in conjunction with Region 6. It's called just-in-time scheduling, and we are at the lowest level of wait that we have ever been historically. So we're very happy with that. The other thing with the support of our county commissioners that we were able to do is we were able to add a 3rd APRN into our outpatient clinic, which again helped address those wait times for individuals that were seeking those services. The complexity of our patient population. The complexity of our patient population continues to rise. People can project that that's due to the downsizing of the regional center. People can project that that's due to the number of individuals with mental health and substance use issues that are landing in Douglas County Corrections or any correctional facility. But the severity of people's mental health issues, the severity of their substance use issues, we predominantly see meth. That tends to be the drug of choice when people are admitted to our inpatient unit if they are co-occurring, if they have both a mental health and substance use issue. And then most of the clients we work with are medically compromised. And so you're really, when you're working with one individual, our providers are working with their mental health, their substance use, and their medical issues all wrapped into one. So that's a lot, that's a very complex population to be working with. Our facility design and has elements that need to be addressed specifically for behavioral health patients. So for instance, our psychiatric intensive care unit, we work within the confines of what has been provided for us. So the best unit we can provide for our PICU is the one that it's on. But there are elements of that unit that make it challenging to work with the complexity of the needs of the clients that we work with. It's an extremely small unit. It's got several areas on it where there are blind spots. You have individuals that are coming in that are not wanting to be there. They've been picked up. They're there on an involuntary basis. You have individuals that have mental health issues and that they haven't been medicated for a very long time, and they've been self-medicating with meth. And so there's the complex, dangerous needs of those individuals. And so you have to think about those things. And how do you address the needs of that population as it continues to evolve? What are the best practices out there? What are the promising practices out there? So that's a challenge for us. Space is always a challenge. And then also preparing for Medicaid expansion. I think that is something that our team really needs to delve into and look at. As I talked at the Board of Trustees meeting, the projected number of individuals has now gone up. I read in the paper yesterday that it's gone up again, another 10,000, and that they're wanting to do Medicaid expansion without any additional financial burden. That means that the services historically, potentially, that people have been able to secure under Medicaid will probably shrink. We do not know what that looks like yet for behavioral health services, but if they look at the core services that are going to be required and mandated, it's going to be probably acute inpatient, outpatient medication management therapy. Some of those other services that individuals that have very chronic behavioral health issues need may no longer be funded. Some of those residential levels of care and things like that, we just don't know yet. So that's something our team needs to keep an eye on. The other thing that I think with an impact on the county financially for this is that there are many providers in our community that choose not to take Medicaid clients. The billing is cumbersome. You don't always get paid on time. And so those individuals are seeking services at facilities like ours at the Community Mental Health Center that will provide services for them. In summary, I skipped a slide again. Boy, there we go. Goals. The Community Mental Health Center continues to work toward meeting our CMS regulations. Those regulations are called conditions of participation. Some of those conditions of participation are called immediate jeopardy. So if you do not meet those at a hospital level of care, you could be at risk of losing your ability to participate with CMS. You would lose your funding and you would lose your hospital license. One of the most recent one is the newest added ligature assessment. Ligature assessment is the ability for people to be able to strangulate themselves or hang themselves on something. So our facility is required every 6 months to go through a thorough ligature assessment and then implement a plan of correction. That plan of correction can be something as simple but costly as you need to replace every single one of your hand soap dispensers because those are not ligature safe. And I know people think that sounds really strange, but people can wrap blankets around those, and if they don't have the right fall on them, they can actually hang themselves from those devices. The ligature safe devices run about $258 a hand sanitizer or a soap dispenser. So these regulations do come with obviously the financial obligation to be able to back those up. It's looking at your doors and can people be able to hurt themselves on that? It's looking at the furniture that are in the patient's rooms, all of those things. We are working with our partners in public properties in regard to the ligature assessment and how we best meet that need. And if it's a consultant that we bring in that has the expertise in this area that can walk along beside us, especially for that first one, because again, this is new to us. There are organizations out there that have been doing these ligature assessments and are very skilled at them that we could certainly utilize their expertise. Our other goal is to maintain our social detox services. This is very challenging because really this is convincing the city the importance of funding the civil protective custody side of those services so we can continue those services. And then also engaging in the Stepping Up initiatives. So we work very closely with our partners with Douglas County Corrections. We are very excited to try and do what we can do to meet the challenging needs of the individuals with mental health and substance use issues that are in corrections. And we look at each of the intercepts in the sequential intercept mapping where we already provide services that we can link up with corrections and make sure that we are supporting them in the best manner that we can support them. So what are we already doing very well? And we know we do this very well, and we can do it for or with corrections. In summary, we continue to look forward to providing services in our community to the underserved of Douglas County. We are very active in supporting any efforts that help develop excellence of care for individuals served in our county.
Well, thank you for that very
Questions?
informative, comprehensive report. We really appreciate you doing this. We will be continuing along this line of inquiry to see how we can help with what you've outlined here as the goals going forward to a real challenging future. I would ask if anybody briefly has any questions from the public. We are at 11:15, and I promised people they'd be out of here now. So, yes,
Luis,
briefly.
Yes, sir. 518 North 40th Street. I just want to comment that the triage therapy and peer support services, when I heard about that and you explained how that worked, I thought that was great. It's an opportunity for the public to understand how the government's benefiting because this is a publicly ran facility. Some people may want to be involved with government, but they don't want to go to meetings like this. Spaces with like a triage or peer support might be an environment that they would participate in. My question is, what information do you have on trauma-informed environments?
That's a very good question. What I will tell you is that the Douglas County Community Mental Health Center has been highly invested in trauma-informed care. It is something that, Luis, that we have been doing for many years. It started out with a baseline assessment called the Trauma-Informed Care Assessment through SAMHSA. And we completed our baseline assessment. From that, we implemented our goals, our plan of action, and then we redo that assessment to make sure that we are continuing on that path to assure that we are providing trauma-informed care services to the patients that we serve.
You redo the assessment?
We do, yes, absolutely.
How often?
Probably I think it's about every 3 years, so we are doing it right now.
Okay.
And we also have a peer support specialist, so somebody in lived recovery that is involved in that assessment with us. It helps us, I'm trying to think of the right terminology, but sometimes I think I do things maybe better than I'm doing them. So it helps keep us, I can't think of the word, but it's that peer might say, I really don't think this policy is as trauma-informed as it could be. And that individual gives us advice on how to make that better.
And that's on your behalf? You're not required by the state, the feds, or the county?
We are actually required by Region 6 Behavioral Healthcare for our funding to do that assessment, and we turn those results into them, and they monitor us throughout our yearly audits to make sure that we're following through with what we said we were going to do. We do the same assessment for its co-occurring assessment as well.
Okay. Thank you.
Good question.
Larry?
Yes, Larry Storr. I'm going to try a hypothetical question here that gets back to what before I was rudely interrupted. Two people, one is me, one is my grandson, for example. And somebody in the crowd says, oh, they both may be having a mental health problem.
Mm-hmm.
The facility you're talking about is a Douglas County facility.
Yes.
And it does have some space at the Douglas County Health Center.
That is correct.
All right. So this gets to my first question. When somebody determines now how I get into the system or my grandson gets into the system, whether it's through corrections, through the school system that said, oh, we got to detain him. The questions are, who makes those decisions? And is this what you're presenting, is that relegated only for alcohol problems? Because behavioral health problems is things other than alcohol. And I want to clarify. And is it also restricted to a certain age limit?
Yes. Our services are provided to individuals 19 years and older, and we are one of the departments located in the health center. So the services that I am the director of are all behavioral health services. And when I say behavioral health, I'm using that terminology to mean both mental health and substance use services. And sometimes those services are combined for the person. So we serve individuals 19 years or older, and the individuals that we serve can come into our services in a variety of manners. They can come in on a voluntary basis. They can come in on an emergency protective custody where they're picked up by the police and brought in for an evaluation and determined if they need additional services. They can.
The general public needs to understand where the line between behavioral and mental health is, because they tend to run together.
Sometimes it is confusing for individuals.
Thank you.
You're welcome. The third category that we take is individuals that are on a Board of Mental Health petition or commitment.
Thank you, and thank you everyone for coming. I appreciate the input, and thanks for a great report.
Thank you.
I really appreciate the comprehensiveness of this report. If you haven't got one, there's some copies here. You can take them with you. We'll follow up with you on future hearings, and we really appreciate your help.
Okay,
Thanks,
thank you very
everybody.
much.
We are adjourned.
Thank you, sir.
Thank you, Jim.
Thanks, buddy. Yep.